Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation. The Sun Health Foundation was the original fundraiser in Sun City that raised the funds to build this hospital where we sit right now. So years ago, in the 60s, Sun City was booming. Del Webb could not keep up with the demand, but we did not have access to acute care. You couldn't get an ambulance to take you to Youngtown or to Central Phoenix because it was too far. And local citizens, who I dearly wish I had met because they were just such amazing people and such forward thinkers, went door to door, raised the money to build this hospital. And Walter Boswell donated the land that this hospital is on, and then they opened this hospital in 1970, which, that's a lift. Think about that, raising all that money, staffing it, figuring that all out. That is what the Sun Health Foundation was founded on. Of course, Sun Health went on to build Del Webb Hospital, and you know, if you saw on our campus these buildings over here, that was the Sun Health Alzheimer's Research Center. And in 2008, we merged all of that under Banner to make it a stronger organization and operation for everyone. But the Sun Health Foundation continues to be the philanthropic partner for all the fundraising for Boswell and Del Webb, and we also raise quite a bit of money for the Banner Sun Health Research Institute. So your participation today is a part of that. We continue to ensure that not only do we have state-of-the-art equipment here and amazing physicians practicing here, as you will hear, but also that we can serve everyone. So a lot of the people who come into particularly this hospital do not have insurance or resources to pay their medical bill, and part of what we do with Sun Health is support the organization financially so that they can deploy those resources as needed. Now I get to introduce our speaker. So Dr. Rahul Sharma is a cardiologist. You knew that before you came here today. And I'm guessing that he travels pretty light. And the reason I say that is he's moved a lot. I was reading his bio. He went from Penn State University to Wake Forest University to the University of Florida, Jacksonville, to the Swedish Heart and Vascular Institute. That makes me stressed because I have to think about how much I would pack up to have to move every time, but has obviously amazing experience and background, and he joined Cardiac Solutions in 2021, and we do a lot of work with Cardiac Solutions. They're a wonderful outfit. He's an interventional cardiologist, and I'm not going to go through all the things he does because I wouldn't even be able to pronounce them all. But it's a wide range of minimally invasive cardiac procedures. I am familiar with the TAVR, which is the valve replacement. And so much is happening in this area of what we can do now that is not as invasive, of sort of cutting you open as we used to do for all these different things. So he does MitraClip, Watchman, so many of these other procedures, which I'm sure he's going to explain to you. What I'd love to hear is he's an active researcher and a journal editorial board member, and his philosophy of care centers on compassion and delivering the most advanced evidence-based treatments. So with that, I'd like you to help me in welcoming Dr. Sharma.
Well, thank you so much, Nora. Good morning, everybody. Thanks for having me. I really appreciate those kind words. For my training, as Nora alluded to, I did move around quite a bit to always put myself in the best possible experiences of mentorship and training throughout all those years. I've been in practice now for almost 10 years. Been here in Phoenix area with Cardiac Solutions for 5 years. Prior to that, I was in my first job out of training, which was at Virginia Tech University in Roanoke, Virginia. So it's been, I can't believe it's almost been a decade that I've been in practice, but it's been amazing. It's been a very revolutionary and evolving time in cardiology, specifically with my expertise, which is in treating heart valve disease. The things that we're doing now and the patient population that we're doing those things in is just something that I think 10 or 15 years ago we could never have imagined. And the envelope continues to get pushed. There are a lot of leading edge therapies that are in development that I'm confident will soon be, at a hospital near you to help treat the patients in our community. So my mission is to continue to push that envelope safely and to really elevate what we can offer patients here in West Phoenix for many, many decades to come. So those are kind of the things that keep me wired and keep me going when I'm thinking late at night about what I want to pursue next for our patients. So thank you for having me, and I look forward to talking with you all. So without further ado, let me get going here with the slides. That's me. So the title of today's talk is Don't Wait for Warning Signs, Heart Attack and Heart Valve Disease Awareness. Of course, I'm sure if I were to take a poll of the audience, many of you could list off several of the symptoms that you've either experienced yourselves or have heard of when it comes to what are the warning signs or possible symptoms of a heart attack. I'm sure everyone in this room has heard about a murmur or what a murmur is or what it could signify. Some of you may have murmurs, or you have cardiologists that are monitoring or tracking that with testing. So I think the level of education in this room and then amongst the general public is actually pretty good when it comes to some of these things. But when you actually experience these symptoms, there's a natural tendency to think, well, what if it's something else? What if it's acid reflux? What if it's not a heart attack? And I think this is where sometimes patients get themselves into trouble. And unfortunately, we commonly see patients come into the emergency room with symptoms that clearly tell me that this was a heart attack, but they've been going on for 10, 12, 14 hours because innocently the patient thought maybe it was something else. So one of my goals in doing these Coffee Connection talks and other public education initiatives through foundations like Sun Health is to really go direct to the person. I want to educate the patient on what they need to watch out for, because it is through that education that we can actually improve outcomes way beyond the reach of what a doctor can actually do with his or her own hands. So there's nothing stronger than the knowledge and the education within the patient to then seek out help. So that's really, I think, the central tenet and mission of why I like talking to patients directly about these educational topics. So that's, again, my introduction. These are the institutions and places I was very privileged to train at and had many mentors that helped to, it takes a village, right, to guide you through and train you. So I'm very appreciative and indebted to those individuals, those mentors, and those institutions. Been in practice here for about almost 10 years. So these are the common cardiovascular conditions that we treat today. And it is purposely that I drew this diagram kind of in this bubble format with these different bubbles touching each other, because the point I'm trying to illustrate here is that these conditions all affect the other. This is truly like a domino effect. If you have blockages in your heart arteries, which we call coronary artery disease, you're also likely to eventually develop congestive heart failure. Or if you have atrial fibrillation, which is an arrhythmia, which is not the focus of today's talk, but it is an extremely common cardiology disease, you can develop congestive heart failure. You can develop heart valve disease. You can have a stroke. So all of these different conditions are all in interaction and interplay with each other all the time. And that's, I think, one of the key things is when I see a patient with a specific medical problem, I'm not just looking at that problem in isolation. I'm thinking about the effect that that problem has on three other things that are directly related to it. So that's the kind of conceptual care that I think the cardiologist or any healthcare provider, no matter what their specialty is, should be delivering to the patient. Not just this unidimensional view, but more of kind of a comprehensive, okay, you have this problem, but it could cause these two other things. We need to take preemptive action to prevent those things from happening. This is the cardiology toolkit. So with all the fantastic procedures we have today, when it comes to diagnosing the problems, we only have a limited number of tools. And we have to use these tools and leverage them to then decide, okay, what's the treatment strategy? The tools we have are the basic EKG. I'm sure everyone in this room, or most in this room, have had an EKG. It's with the stickers and the wires, and they print out what your heart rhythm is doing. That is, bread and butter cardiology. It's available in your primary care doctor's office, widely available, very, very inexpensive, very informative. But beyond that, we have the echo, which is the ultrasound of the heart. We can do heart rhythm monitoring, where you wear an external monitor or maybe an implanted monitor that can monitor your heart rhythm. We can do stress testing. Stress testing traditionally is done with a treadmill, but can also be done for those who cannot walk on a treadmill with a chemical or a medication that makes your heart think you're exercising, even though you're sitting still. And that's for folks that can't walk on a treadmill. So that's called a chemical nuclear stress test. Obviously, blood work and lab testing. Invasive procedures like a coronary angiogram. That's a procedure, I'll show you some images, where we go in and look at the heart arteries to see if there's blockages. We can do electrical studies of the heart, which are called EP studies. Those are done by the electricians of the heart. We can do ultrasounds where we introduce an ultrasound probe down your throat into your esophagus, using sonar technology to create an ultrasound image of your heart and the valves in the heart, which goes beyond just the regular kind of ultrasound that is done from outside the chest. And this procedure, this transesophageal echo, which I do quite a few of, gives us a really close upfront look at the heart valves and the structures in the heart when the ultrasound from outside the chest isn't telling the whole story. And then there's advanced imaging with CT scans and MRIs of the heart and the structures of the heart, which give us additional details and information as well. So this is the 2026 Cardiologist Toolkit. And this is what we rely on every day when we take care of our patients. So what is coronary artery disease? Because before I talk about the warning signs of a heart attack, I don't want to just talk about that in isolation. I want all of you to understand what's actually happening that leads to that event, so that with that knowledge, you can make better decisions, whether it be for yourself or advising a family member, friend, a neighbor who may be having symptoms. Coronary artery disease is simply a process where a plaque begins to grow in the heart arteries, the coronary arteries. This plaque starts in your teenage years as a little fat deposit on the wall of the vessel. That fat deposit, for a variety of different reasons, continues to grow over time, over the course of years. The body sees that as an injury to the vessel wall and immediately, instinctively, begins to try and protect that area of injury by growing a calcified shell over this fatty plaque. So imagine you got a snow plow, and over the snow plow, there's this layer of cement, or whatever you want to call it, that's kind of encapsulating it. That's what a calcified plaque is. It's a hard shell with a soft cholesterol lipid core. And that's how these plaques start. Over time, the plaques grow. You can see the illustration here. The image on your extreme left is a relatively open vessel. That central channel where the blood cells are flowing is relatively open. As you move to the right, the plaques begin to grow slowly over time until you get to the extreme right-hand side illustration, where you see you have a much larger plaque and such a small channel for the blood to flow. So this is the process of atherosclerosis, or coronary artery disease in the heart arteries. And this process, when it happens slowly over time, is what eventually then leads to, hey, Dr. Sharma, I was at the gym the other day, and I started having chest pain when I was exercising on the treadmill. I had to stop and rest. This is the classical symptom of severe coronary artery disease. That is exertional-related chest pain. So when patients come to see me and say, hey, I was watching TV the other night and I started having pain in my left chest, And then I ask them, well, do you exercise? And they'll say, yeah, I go to the gym, I walk on the treadmill, I do the elliptical. You ever have any chest pain when you do those things? And they'll say, no, I feel great when I do those things. So that immediately tells me that they probably don't have severe coronary artery disease, because if they did, they should be having chest pain when they're on the treadmill or the elliptical or walking at Walmart or carrying groceries from the car into the house when they're doing physical things. And if they don't have symptoms during those moments, but they have some random chest pain when they're just sitting and watching TV, that's not very typical of coronary artery disease. So just by taking a history and talking to the patient, you can make a lot of conclusions. Now, does it stop there? Do I just then say, oh, it's probably not your heart, and then move on to the next patient? No. Okay. We bring a level of sophistication to what we do. We don't just go off of someone's description. Sometimes descriptions aren't accurate, and sometimes the body doesn't read the textbook, and patients will have, atypical presentation. So we do testing, but that clinical history gathering gives you what we call the pre-test probability. What are the odds that the test is going to show something? So this is the concept of how coronary artery disease develops. What are the symptoms of severe coronary artery disease? Well, like I described, activity-related, exertion-related symptoms, whether it's chest pain with activity, shortness of breath with activity. You could have this odd sense of nausea, like, hey, I was on the treadmill the other day and I felt okay, but when I got off, I was nauseous for like an hour afterwards. That could be the sign of severe coronary artery disease. And in fact, many times in women, post-exercise nausea will be an example of what they may feel, and they may not identify that as something having potentially to do with their heart. Fatigue, you just feel washed out after doing something so simple. Lightheadedness, dizziness, particularly after exercise. And we call chest pain angina. That's the medical lingo that we use. And that kind of angina after activity or exertion is a major sign of potential severe coronary artery disease. So what is a heart attack then? What is a heart attack? How is that related to coronary artery disease? A heart attack is a little bit different. There is a lot of misconception in the general public about what a heart attack is. When I listen to patients describe to me either something from their past or something related to someone in their family, I can't tell you how many times the phrase heart attack is incorrectly used. And it's probably because maybe the medical community has done a poor job at educating the public on what a heart attack is, but there's a lot of misconceptions around it. So I want to try to explain it in a way that helps to set the record straight, at least for all of those here in the room. And then I'll rely on you guys to be heart attack definition evangelists and go out there and educate people on what a heart attack is. So imagine the blood is flowing through the coronary artery. It's doing great. It's minding its own business. As the blood is flowing through the vessel, it sees, oh, I'm passing by this part of the artery where there's a plaque. Okay, I'm going to go further down. There's another plaque. There are these different plaques that are lining the wall of your vessel that begin in your teenage years and they progress throughout your life. Now, let's say you're 65 years old. Your blood's flowing through the artery. One day, for an unclear reason, one of those plaques, which may not be a severe plaque, it could just be a mild plaque, it suddenly cracks open. It just cracks open. When it cracks open, the body sees that it's got an injury. So it sends helper cells to the site of the crack in the plaque to seal it. When it does that, it goes into overdrive. It does too good of a job. And it creates a clot with something called platelets, which are little cells traveling in our bloodstream. Creates a clot on top of that cracked plaque. The clot grows and grows and grows. And within a matter of seconds, everything I just described happens within seconds, the artery shuts down completely because it's blocked by a clot. That's a heart attack. Now, the artery can become 100% blocked in a matter of seconds, or it can become 99% blocked. But it's going to become majorly blocked by this sudden clot that grows on this suddenly cracked plaque. That's what produces a heart attack. Now, what makes the plaque crack open suddenly one day? We don't know. We know there's things that are correlated with it. For example, on the East Coast right now, there's a ton of snow. And there are countless people who are out there shoveling snow. And that level of activity is not something that those people commonly do. And unfortunately, many of those individuals or some of those people are going to have heart attacks. Maybe it's sudden extreme physical activity that could crack a plaque open. Or maybe it's a personal stress factor. You're having an argument with someone. You've learned about someone's death. Something that emotionally stresses you out. That could explain it. We don't fully know what causes it, but we know that something cracks the plaque open and a clot grows and shuts the vessel down. That's what produces a heart attack. Now, believe it or not, we all, even some of us right now in this room, are having plaques crack open inside of us right now. But it's not leading to a heart attack. So what's the explanation there? I thought, Dr. Sharma, you just said when this plaque cracks open, it always causes a heart attack. No. To make matters more complicated, believe me when I tell you, many times when these plaques crack open, they actually heal themselves and it never results in a heart attack. But in some cases, it goes into this overdrive process and a clot forms and it shuts the vessel down. How do we know this? We know this from clinical research studies and postmortem studies that have looked inside arteries and seen plaques that are cracked open, but no actual heart attack occurred. So we know that not every crack in a plaque causes a heart attack, okay? But the ones that are fated to cause it are the ones that cause it, and that's where the heart attacks originate. So that's a heart attack. It's a sudden blockage in the artery, oftentimes from a mild, innocent plaque that would never have been detected on a stress test. So now here's the second point. You go to your cardiologist tomorrow, and he or she puts you on a treadmill, and you get a stress test, and your stress test is normal. If your doctor says to you, well, Mrs. Smith, your stress test looks great. You're good. You're not going to have a heart attack anytime soon. I would hope no cardiologist would ever say that, but that is completely scientifically false. And we all can perhaps name examples of people, or whether they're famous people on TV or people we know, who had a relatively normal stress test in the recent past, but then ended up having a heart attack. Well, what's the explanation there? Well, I just told you, heart attacks usually happen from the mild plaques that suddenly crack open, cause a clot, and shut the artery down. And mild plaques will never be detected on a stress test. Stress tests are only designed to detect severe plaques. So, if you get a stress test and it comes back normal, don't let someone tell you that your arteries are normal. That's not what the test means. It just means that you probably don't have a severe blockage. It doesn't mean that you don't have some plaques. There are different tests if you want to really know whether or not you have plaques, but a stress test is not going to tell you that. So, very important to know when a doctor walks in the room and tells you your test looks good, the next question should be, what does this test even mean? And what does this test actually implicate? So, a heart attack is a sudden blockage in the artery by a clot. Now, when that happens, the clock starts. Much like if you're having a stroke, you may have heard the mnemonic for stroke patients is be fast. Identify strokes rapidly, get to the emergency room. Certain patients could benefit from a clot-busting medicine to help alleviate the damage being caused by the stroke. Well, it's a similar concept in the world of cardiology. If you're having a heart attack and the artery is shut down, time is muscle. We've got to get that artery open to restore blood flow and help limit the damage that's occurring to the heart muscle. So when patients come in to the emergency room at Boswell or Del Webb or wherever, and they're having a sudden heart attack, we've got 90 minutes to get the artery open. So imagine the disservice that the patient may inadvertently or innocently be doing to themselves if they're waiting at home for 8 hours with symptoms, not knowing. It's not their fault. They didn't know they're having a heart attack, but now we're 8 hours behind the 8 ball. And then we have 90 minutes to open the artery, but the cat's already out of the bag. The damage is already cemented in because the artery's been shut for all those hours. And we go in and open it and restore the blood flow, but it might be too little too late. And that doesn't stop us from still opening the artery. We still want to minimize the damage. But being at home for several hours with a heart attack, which unfortunately is still way too common, is a major culprit for how heart attacks lead to permanent heart muscle damage. So being aware of the warning signs of the symptoms is so important from a public health perspective. So heart attack symptoms, chest pain at at rest or in the midst of physical activity and it's not going away. You waited 15, 20 minutes, the pain's not going away. You got to call attention to it. Or maybe it's sudden shortness of breath. Maybe it's nausea. Maybe you're just drenched in sweat for no reason. That's called diaphoresis or sweating. That's a major potential symptom of a heart attack. Severe fatigue, you feel washed out, lightheaded, dizzy, or you're going to pass out, or you feel like you're going to pass out. These are some of the symptoms that we know about in patients who are having actual sudden heart attacks. So a little stomach upset, a sense of nausea, a little vague chest pain, these could even be milder versions. And you can understand easily how someone might explain that away as, hey, maybe it's my lunch that I just ate, it's upsetting my stomach, let me take a Tums and wait a few hours. And you may have the misfortune of it being sitting on essentially a heart attack and not knowing. And then later on, you go to the emergency room, you find out, you're several hours into this. So this is how it takes people by surprise, including physicians who've had heart attacks and also innocently thought, hey, I don't think this is my heart. And then hours later, they end up going to the hospital finding out it was a heart attack. So it's not just something that potentially could be misunderstood by non-physicians. It's anyone when you're having symptoms, the natural reaction is to first assume that it's not something significant before jumping to major conclusions. So it's one of the challenges of identifying this, is kind of coming to grips with the fact that, hey, I need to seek help, I don't feel right. The treatment approach is get the patient to the emergency room, stabilize them with medications, and take them urgently or emergently to the cath lab for a coronary angiogram. That's a procedure where we go in with a catheter, either from your wrist or from the artery in your groin, and up into the heart, and we use contrast dye to then look at the arteries under an x-ray camera, find the blockage, and try to open the vessel using balloons and stents. And then sometimes if patients are really sick from their heart attack, they need to go to the ICU afterwards or get critical care support for the sickest patients. So interventional cardiology is the branch of cardiology that now wanders into doing minimally invasive procedures. Not every cardiologist you see is an interventional cardiologist. In fact, most cardiologists in America are not interventional cardiologists. They are what we call general cardiologists or medical cardiologists. Those are physicians that are cardiologists, but they don't do these invasive heart procedures. They treat patients medically, and then they refer patients to those of us that are interventional cardiologists to do these procedures. But interventional cardiology is that kind of sect or branch of cardiology that's devoted to doing minimally invasive procedures with catheters. So if you come into the hospital with a heart attack, it'll be an interventional cardiologist that takes you to the cath lab to potentially open up your artery. Coronary angiography is the central pillar or foundation of interventional cardiology. It is a procedure where we go in with a catheter and look at your heart arteries using contrast dye. This is an example of a recent heart attack patient that I treated. The image on the left, which I've labeled image A, is an artery originating off the aorta, which is the central vessel in the heart. This is an x-ray image, and you can see that there's like this stump, and then you don't see anything else beyond that. After we get the artery open with a balloon and a stent, now you look at image B and you see this entire kind of C-shaped vessel. Okay, this happens to be the right coronary artery, which is the artery that is on the back of your heart. But this is what a heart attack is. The artery is completely shut down on the image on your left with a clot, and we go in and balloon that clot open, put in a stent, which acts as a scaffold to keep the artery open. And now look, blood and contrast dye is flowing nicely all the way down the vessel, and the vessel is now open. So this is the concept of what we're doing in the cath lab when we are treating blocked arteries with stents or balloon angioplasty. This is now another patient that I treated not too long ago who didn't have a heart attack. This was a patient who said, hey, every time I go to the gym and I get on the treadmill, I'm getting chest pain. I have to stop and rest. I can't go as far. I can't do things around the house. Something's not right. And the patient had a stress test. The stress test showed evidence that he has a severe blockage. And so then I brought him to the cath lab to do an angiogram to identify if, in fact, there are severe blockages. And we found that he has severe blockages. The artery on the image on your left is, again, the right coronary artery, this kind of C-shaped vessel. And you can see the contrast is coming into the vessel, but then in the middle of it, it kind of thins out. That's the area of the severe blockage. And the panel in the middle is one of his other arteries. Same patient, the widowmaker artery, which is what's depicted in that central panel, which also has a severe blockage in it. And then yet a third artery on his heart that has a severe blockage in it as well. So he had blockages in all 3 heart arteries. And his only symptom was, hey, for the last 6 weeks when I go to the gym, I'm having trouble on the elliptical, on the treadmill, I can't do things. And it led him to then present and get identified. We consulted an open heart surgeon to talk about doing bypass surgery on him because he had blockages in all 3 vessels. Because of his age and his other medical conditions, the surgeon felt he was too high risk to have open heart surgery. So we're not just going to leave him with these blockages. We still have to treat them. Bypass surgery is not an option. So I went ahead and fixed these blockages with stents. And this is an image. The image on your left is me drilling down on the calcified blockage. Remember, I explained to you these plaques are calcified when they grow over time. Well, some of these plaques get very calcified. You can't actually put a stent unless you shave the calcium down. So I'm using a diamond-encrusted drill bit on the image on the left, diamonds being very good at shaving calcium, and shaving and drilling the calcium down before then putting in a stent and opening up his widowmaker artery. So this is a little bit of a different flavor. I'm showing these pictures to you guys purposely because I want to show you the difference between the patient who comes in at 2 in the morning because he woke up from his sleep with crushing chest pain. He's having a heart attack. His artery's totally blocked, and we have to open it. Versus the patient who tells me that over the last month and a half, he's been having chest pain on the elliptical, but he feels fine otherwise if he's not doing any exercise. And he ends up having severe blockages, and in a more kind of elective way, we treat him with stents. You see these 2 different patients? They're very different in their story. They're different in how they're presenting. This is the spectrum of what we see every day in patients with coronary artery disease. There's the alarming presentation with a heart attack at 2 in the morning. And then there's the more kind of quiet, slow presentation where, hey, I don't feel right when I'm exercising. Both patients have a problem, but one is on a more extreme end of the spectrum with a more urgent problem, and the other is in a more kind of stable-ish, safe end of the spectrum where we have time to treat them and try to improve the blockage with stents so we can improve their exercise capacity. So that's the kind of spectrum of what we deal with coronary artery disease. Okay, let's take a pause for a minute and summarize what we've talked about so far. It's a lot of information, download, or in your case, for you guys, upload, right? But so what we talked about so far is cardiology toolkit, the different tests and things that we can do to treat and evaluate patients. We talked about the warning signs of a heart attack, and we kind of contrasted that to the warning signs of a severe coronary artery blockage, which is, hey, I'm exercising, I get chest pain, I have to stop. We talked about coronary angiography, a heart catheterization, where we go in and open up these blocked arteries, sometimes in the middle of the night in the case of a heart attack, or in the middle of the day in a case of a more planned procedure. So these are the things we've covered so far. I'm going to kind of go now into one of the related, you remember that diagram I showed in the beginning with the different bubbles of different heart diseases. We're going to talk about heart valve disease in kind of the closing portion of this talk. But just remember that kind of the central foundation of cardiology and interventional cardiology is coronary artery disease and the treatment and management of it and the symptoms of it. And so remember those warning signs, remember those symptoms in your day-to-day life and when you're communicating and interacting with those you care about, people you know, because empowering the patient community to know these things, I think, is one of the biggest ways to drive better outcomes and see patients in the hospital sooner. So now we transition to heart valve disease awareness. Well, I think most, if not all of you know that there are these 4 valves in the heart: the aortic valve, the mitral valve, the pulmonic valve, and the tricuspid valve. And I mentioned those valves in that specific order because I'm going from the valves on the left side of the heart to the valves on the right side of the heart. The aortic and mitral valves are on the left side, and they're regarded to be the most important. But the valves on the right side of the heart, which are the pulmonic and tricuspid valves, are pretty important too, as we've learned in the last decade. And so we have treatment options to treat all 4 of these valves when they fail. For the longest time, the only treatment option was open heart surgery. You get your valve repaired or replaced by having your chest cut open. But now, in recent years, we've developed minimally invasive procedures with a catheter where physicians like myself can go in through the groin and repair these valves or replace these valves without having to put the patient through open heart surgery. And that is what drives and motivates me, because that's a revolutionary area of cardiology. It's becoming in many ways mainstream. I don't want to make it sound like it's that new, but it's always evolving, and there's new devices, new techniques, new approaches coming out. So it's really truly like the forefront of cardiology and what we call structural heart disease of cardiology. So that's basically a definition of what is structural heart disease. It is the branch of interventional cardiology. So now we're talking like further specialized. It's a branch of interventional cardiology that has to do with treating heart valve conditions through minimally invasive catheter approaches. And the focus is treating the failing heart valves, but also it includes treating holes in the heart and other inherited or congenital heart conditions as well. So that's what structural heart disease is. It's all these different conditions impacting each other. The heart valves, when they can fail either because they're getting narrowed, which is called stenosis, or they can fail because the valve is leaky, which is called regurgitation. And then other congenital conditions of the heart, like holes in the heart. People are born with holes in their heart. Those holes may need to be closed. Or patients have atrial fibrillation, and they can't take their blood thinner to protect them from strokes. So we have to put a plug in the heart, which acts as a filter to protect them from stroke so they can get off of their blood thinner. That's called the Watchman device. So these are the things that are encompassed in the world of structural heart disease procedures. The aortic valve, the king of structural heart disease. It is arguably the most important valve in your heart. And as we age, it becomes calcified. Again, this theme of calcification is carrying over through everything, right? The aortic valve gets calcified. It becomes hardened. It doesn't open normally. And when it doesn't open normally, blood can't exit the heart. So we, at that point, when it becomes severely narrowed, we can replace the valve, and we can go in through the groin and put a brand new valve in and cure this problem without ever opening the chest. That's called a transcatheter aortic valve replacement, or TAVR procedure, which truly has become mainstream now. And in America, it has overtaken. In terms of aortic valve replacement, there are more transcatheter aortic valve TAVR procedures being performed than there are now open heart aortic valve surgical replacements being performed. So this is going to continue to be, this is here to stay in terms of this approach. So the different treatment options for severe aortic narrowing or stenosis are you either get open heart surgery and get the surgeon to put a brand new valve in directly, or you get the procedure done through the groin and have someone like myself put in a TAVR valve. Those are your treatment options when this aortic valve becomes severely diseased. So TAVR has taken over as mainstream in America. This is a moving image of a valve replacement I performed on a patient with severe aortic valve stenosis, or narrowing of the valve. You can see this valve is being expanded on the image on the left with a balloon. A balloon is expanding this valve and allowing it to crush the native valve that's diseased, and this new valve expands in its place. So that means the valve that I'm putting in is not stitched to anything. It is literally anchored there by the calcification that's on the diseased valve that is acting as a glue or a scaffold to help hold the new valve in place. So how come this new valve then isn't sliding around or coming loose? Well, we size it a certain way so it's nice and snug and tight in there and doesn't move. And that takes some advanced measurements and things that we do. And of course, these valves come in some different sizes. But the calcification that's on the current diseased valve truly acts as a scaffold. The image on the right is yet another valve TAVR replacement procedure that I'm performing. This time, though, look at the valve. It looks different than the one on the left. It's a totally different kind of valve that's available here in the U.S., made by a different company, which is yet another valve that we can use from the groin. So we have 3 different valve types, 3 different valve companies here in the U.S. for the TAVR procedure. So when we see a patient, we do various tests, including a CT scan, to understand what valve is best for that patient. But the majority of valves in America that are put in through the groin are the valve that you see on your left, which is manufactured by a company called Edwards Lifesciences. But there are 2 other companies, Medtronic and Abbott, that also manufacture these valves. So Edwards has the lion's share of the market, but Medtronic and Abbott have a minority share. So that's kind of the landscape here in the U.S. as to the valves and the valves that we use for the TAVR procedure. Moving on to a different valve issue that I treat is a totally different world, which is called mitral valve regurgitation. That is, the mitral valve is severely leaking. So this is a different process than aortic stenosis. This is a process where there's blood flow going backwards across the mitral valve, regurgitation to a severe degree. Patients are short of breath. They can't lay flat at night when they sleep. They're sleeping propped on 2 pillows. Their legs are swollen. They're severely fatigued. These are the symptoms of severe valve disease, including mitral valve regurgitation. And the awareness for the general public should be, hey, I have swollen legs. I'm short of breath. I'm not able to have the energy level that I did 6 months ago. I need to go get checked out. Maybe I start with my primary care doctor, eventually may end up getting referred to a cardiologist, or if you already have a cardiologist, you bring this to their attention. But the point is that an echocardiogram, which is an ultrasound of the heart, can be done to look at your heart valves to try to understand, are these valves diseased? Is there a problem with this patient's heart valves or not? And so this image here that you see on the screen is showing a ultrasound echo of the mitral valve, and you see this rainbow-colored stuff going up backwards across the valve. That is the representation on an echo of regurgitation, or blood flow going backwards. So this valve needs to be repaired. This patient is extremely symptomatic. The treatment options, again, open heart surgery to repair the mitral valve surgically by cutting the chest open, or go in through the groin and repair the valve with a clip device, almost like a little metal clothespin that goes in and cinches the valve tighter to reduce the leaking. That's literally what the clip does. And for patients who are too high risk to have open heart surgery, we use this clip device to treat and manage this severe leaking of the mitral valve. And here is a picture of what the clip looks like. It's this kind of Y-shaped or V-shaped clip that has these grappling hooks on it, and it goes in and grabs the valve leaflets and brings them together. And that's the concept of the mitral valve clip technology. So here is a procedure called a MitraClip being performed by me on this leaky valve. You see the image on the left before we fixed it, all that rainbow colored stuff going backwards, that's the regurgitation. And now look at the image on the right after we put the clips on the valve. You can see there's much less of that rainbow colored flow going backwards. So this was a patient who then went home the next day after the procedure. Valve is repaired, no open heart surgery, breathing better, less leg swelling, feeling better. So really just, leaps and bounds beyond open heart surgery and being in the hospital for 7 days and then recovering for 2 months. So it's just been a revolutionary time in cardiology. This is yet another valve issue that I treat, which is tricuspid valve regurgitation. Now we're moving over to the right side of the heart where the tricuspid valve plays. And that valve can severely leak as well, just like the mitral valve that I just showed you. And there's a clip device for this problem too, which again, through the groin, under anesthesia, takes an hour, maybe 2, put some clips on the valve, reduce the leaking, patient goes home the next day, hopefully feeling much better. So again, just incredible things that are possible. These are ultrasound images showing a leaky tricuspid valve. Again, using the clip procedure to treat that leaky valve, bringing the edges of the leaflets together, placing the clips, and now look, the same patient, image on the left, another ultrasound after the procedure, showing very little blood flow, very little multicolored rainbow flow going backwards, so the leaking has improved dramatically. And here's an X-ray image on the right, showing you those 2 clips just kind of bouncing around and moving with the heart. The device on top of that is actually a loop recorder. I don't know if anyone in the room here has a loop recorder implanted in them. It's an implanted heart monitor. It's not in the chest, it's just under the skin, but you're seeing it on this X-ray image, but it has nothing to do with the procedure, but the clips you can see are moving with the heart. So this has been a game changer. As I mentioned, 1 night in the hospital, typically, done under anesthesia, done from the vein in the groin, and improves symptoms. Reduces hospitalizations related to congestive heart failure. So really, again, I use the word revolutionary, but really revolutionary stuff in the treatment of patients with heart valve disease. So, Benjamin Franklin said, an ounce of prevention is worth a pound of cure. I've spent virtually all my time with you all today, talking about these fantastic procedures. But I'm sure you all are astute and noticed, hey, these procedures are coming in at the 11th hour when the cat's out of the bag, and we're decades into a disease process. And these cardiologists are then treating this condition. And yeah, kudos to them. They're treating it well. Patients are feeling better. They're living longer. But what about never getting there? What if we could do something to never get there? And I don't know if we'll ever be able to prevent something from ever happening, but we should at least try to educate the younger population, the patients who are in their 30s, 40s, even into their 50s, who have a chance to impact what their trajectory is. It may be difficult to do that in those who are in their 70s and 80s because of just the nature of many diseases increase with age. But we really need to do a good job as physicians to educate the younger patients in our community to seek healthcare, seek preventative care, get on top of their cholesterol levels, get on top of their diet, their exercise, their weight, all these things that are painful to sometimes think about and implement in your life, but are the things that are the secret sauce of preventing something that might befall you when you're 75 or 80 or older. So prevention is, worth a pound of cure, as Ben Franklin said. So I think this is my final slide, but basically the key points of prevention are lifestyle modification. When you're in a position to modify those risk factors, modify them. Take control of these things. Getting a coronary artery calcium score. This is a simple CT scan. It's done at any outfit that has a CT scanner, Simon Med, Banner Imaging, wherever. It's unfortunately not covered by insurance, but thankfully it's cheap. It costs, and by cheap I mean it's regarded to be cheap. It's somewhere between $80 and $100. And all things considered these days, what it costs to go to a restaurant and have dinner, 80 or 90 bucks is not much to get a coronary calcium score. And it will tell you how much calcification is on your heart arteries. Now, that may not be a very relevant thing to someone who's 75, because we expect that when you're 75, you're going to have calcification in your arteries, and we wouldn't necessarily do anything different other than monitoring you for symptoms and so forth. But it means a lot to someone who's 40. It means a lot to someone who's 50 or 60. Because that's in a situation where you have a patient who maybe can get on a cholesterol medicine and prevent that calcium score from getting worse. Or a patient who maybe has prediabetes and can maybe lose 20 or 30 pounds and bring their hemoglobin A1C down and come out of that prediabetic range. It's an opportunity to do something when you get empowered with a score or knowledge about how much calcification is on your arteries. Because as I explained to you at the start of this talk, just to loop back and link it all up, calcification is at the heart of what is happening. It's everything. Calcification in the artery causing plaques getting bigger, causing severe blockage. Calcification on the valve, causing the valve to narrow. Leaky valves, all these things, the calcification process is at the center of it. So knowing your calcium score empowers you to then potentially do something to affect those things. Obviously, lifestyle factors, dietary factors, and then lastly, if you have heart conditions or actual other diseases like diabetes, high blood pressure, taking goal-directed medications and treating those conditions to the fullest extent that you can is important to prevent them from then manifesting bigger problems within your heart, your lungs, your kidneys, your other organs. So prevention is key. Closing thoughts. Know the signs and symptoms of heart attacks and coronary artery disease. Be aware of it. We'll never totally be able to educate each and every person in the world, but we can certainly try. And empowering patients to recognize that, ask questions of their physicians, present to the ER if something's wrong. Worst case scenario, you go to the ER, you lost a few hours of your day. But best case scenario, you identified a problem and potentially jumped on it. So heart attack awareness, symptoms really key. There are advanced minimally invasive treatments for heart valve conditions and coronary artery blockages, as I illustrated and showed you all today, to give you a flavor of what we are doing in the cath lab on a daily basis. And it's really amazing and exciting and humbling, and it's a privilege, but it would be great to not get there, to try to prevent that when we're earlier in our lives. But it's also reassuring to know that for those who do have those issues, we can treat them, and we can treat them safely and successfully without doing anything terribly invasive like cracking their chest open and doing open heart surgery. Now, in some situations, we still need open heart surgery. We need our open heart surgeons to perform cardiac surgery, very much so, for conditions that are best treated surgically. But for those that can be treated less invasively, we work collaboratively with our surgeons to provide those treatments. So I'm a huge fan of our cardiac surgeons, and we still need them, and we need more of them. Identification and referral for treatment of heart valve disease conditions and sending patients to cardiologists for echoes, consultations, really important stuff. You may find out in the end that you only have mild heart valve disease, but now at least you know it. And echoes can be done every 2-3 years to track it and monitor it so it doesn't sneak up under your nose. So those are kind of the central thoughts and themes of what I wanted to share with you all today. And with that, I don't know if I'm over time, but I'm going to stop. But thank you all for your attention. Open to any questions. Nora, let me know.
Yeah, please. We have time for questions, and we do have a roving microphone, so we can all hear your questions. Is it on?
Does the CSC score tells you your valve disease also?
No, it's only looking at the coronary artery scores. Yeah.
How do you find out your valves?
Ultrasound, echo. So you get an echo of the heart. It'll show you your heart valves and whether there's any heart valve disease.
Excuse me, Dr. Sharma.
Yes.
When you replace the valve, put a clip in the valve, what's the 5-year survival rate?
I'll speak. There are two kind of clips that we use currently. One is the mitral clip for the mitral valve. And the mitral clip device, when it was approved by the FDA many, many years ago in 2013, 2014, it was only studied in patients who could not have open heart surgery. Those were the sickest patients. And so those patients didn't have great 5-year survival rates anyhow. When we do MitraClip in those patients, we increase their lifespan. But the 5-year survival rate in that particular patient population wasn't great because they were 85, 90-year-old patients, and most Americans don't live till they're 95 or 97. Since that time, since the clip was approved, there have been newer data, newer trials, newer registries that have been done showing that in younger patient populations, healthier patient populations, not someone who's 90, but maybe someone who's 77 and gets a mitral clip procedure, the 5-year survival rate in that patient is over 90%. Now, we're starting to do clinical trials in lower and lower risk patients with the clip device. So stay tuned. I think we're going to get great data. The procedure itself is very safe. As long as you pick a patient that has, good chutzpah to survive, your outcomes should be good. But we don't always get to choose patients, right? Patients that are the sickest, sometimes are the ones that need us the most. And if we can give them 1 or 2 more years of good quality of life, sometimes that's all they want. That's the softer side of cardiology. Now, the other clip we use is a tricuspid clip. The tricuspid clip is a much newer device. It was just approved last summer here in the U.S. commercially. We've done a ton of cases at Boswell with it. And that device is, again, being used in people with severe leaking of the tricuspid valve who are the sickest. We don't have 5-year data on those patients. So that's more in its kind of infancy in terms of what we understand about it. We do know that the tricuspid clip improves symptoms, it reduces hospitalizations, but it has not been shown yet to increase lifespan. So when I see a patient with severe leaking of their mitral valve, I give them a very different speech. But when I see a patient with severe leaking of their tricuspid valve, my speech to them is, hey, you have severe leg swelling, you're short of breath, you have fluid building up around your lungs, around your belly, we have to constantly go in every few weeks and drain that fluid. Your quality of life is not what you want it to be. By fixing your tricuspid valve, I can reduce your swelling, I can improve your breathing, I can improve your quality of life, but I can't help you live longer. And they almost always will say, I'll take it. Because whatever life they have left, they'd rather spend it at home, breathing better, than being in and out of the hospital, getting drainage procedures, getting admitted with heart failure. So questions about 5-year survival rate are great questions, but what I'm learning and through my journey as a cardiologist is that we always put a dart on this term of survival, because survival is really what it's all about, no question. But I'm learning that there is this group of patients, when they come to me, the theme, the message in their eyes is not about survival. They've lived what they feel is a full life. It's about quality of life. Whatever years they have left, they want that quality to be better. So a lot of what we do in cardiology is about tailoring ourselves and our treatment recommendations to what the goals of the patient are and empowering the patient to be a part of that decision process. So sometimes the survival rates that are quoted for these new devices aren't the cat's meow, but then sometimes it's not about survival, it's about just improving their symptoms. So great question, but I'm learning in my journey now in my 10th year of practice that sometimes there's so many nuances about survival versus quality. Now, last thing I just want to say with the TAVR procedure, which is the aortic valve replacement, tremendous 5-year survival rates, 8-year survival rates have also been published. So as these therapies become more mainstream, more cemented, the survival rates start to get their focus and we get better and better outcomes. Next question. Yeah.
What is the status of transcatheter mitral valve replacement?
Great question. This is something that has been studied through clinical trials for the last few years. Some of those trials are still ongoing. Just recently, within the last month, the FDA has approved commercially the very first transcatheter mitral valve replacement device, meaning through the groin, inserted through a tube or a catheter, no open heart component to the procedure, totally transcatheter through the groin. This device is manufactured by Edwards. It's called the M3 valve. And I guess they're naming their valves after BMWs now. But this valve is a revolutionary product, technology. I suspect in the next 6 to 9 months, it'll become kind of commercially rolled out. See, the problem is it got approved quicker than the company thought it would. And now they've got to hire clinical technicians and representatives to then disseminate and sell these devices. So there's always a little lag there. And then, of course, it's not just about FDA approval. Medicare, CMS has to also approve it. So there's going to be some time. It's not going to be available next week as much as I'd like it to be. But yes, it's a really exciting time. And there are 2 more valves in the pipeline that will be coming as well. So there's a lot of exciting stuff going on in the world of mitral valve transcatheter replacement. So I suspect that the clip device, which I showed you some pictures of for the mitral valve, has a home in the future of repairing the mitral valve. I think most mitral valves will still be repaired with clips. But there will be some that will have to be replaced, and we will now have options to replace them as well without opening the chest. Very exciting. Yes, questions? You got a roving mic there. Yeah.
I wondered if you could please tell us what the symptoms are for women that are having a heart attack.
Yeah. So the symptoms that I shared with you all are the symptoms. But what's important to know is that the symptoms in women could be some of the specific ones I showed, not necessarily the classic chest pain. So what we learn in cardiology, or what we tell patients, is men may be more likely to have that crushing chest pain, breaking out in sweat, being like gobsmacked by the symptoms. But the symptoms in women could be different. It could be, I'm just really tired today, and I feel nauseous, and I have this vague heaviness. I can't describe it. Kind of a softer, milder type of presentation. And you can appreciate how one could go hours without potentially then seeking help. So I always tell female patients, like, hey, it may not be crushing chest pain. It could be nausea. It could be severe fatigue. It could be upset stomach kind of feeling, lightheadedness. Those are really the symptoms in women. And for every time that you have those symptoms and it's not a heart attack, it could be something else. So that also kind of is a challenge, because you may go to the hospital and find out, hey, it's not a heart attack. And the next time you have those symptoms, it could be a heart attack. So it's really hard to then kind of pinpoint that. But yeah, and this is the challenge, is that the symptoms can be different in women, and people can have jaw pain, ear pain. There's this focus on the left side versus the right side. So left-sided jaw pain, left-sided ear pain. I had a female patient a few months ago who was having a heart attack, and her symptom was just pain along that left jaw and ear area. It was going on for a few hours, and she went to the emergency room thinking there was some TMJ issue, but it was a heart attack. She didn't have a lick of chest pain. So it's not as easy as the slide makes it look, but yeah. Question? Yes?
Take one more. Right there.
Regarding cardiac artery disease, or CAD. My wife and I sat through Zoom presentation here a year and a half or so ago. For arteries that are plugged and you've had a bypass and subsequent to that had stents put in, apparently there's something new on the market that, for lack of a technical term, you can go in and rotor the original blockages to open those. Can you speak to that? Is that viable? Is it...
Yeah. What you're referring to is what we call CTO-PCI, that is chronic total occlusion opening or intervention with stents. Many times the vessels that are bypassed by a surgeon are vessels that are 100% shut. So the surgeon goes in, opens the chest, does a bypass. You kind of build a 303 around the 101. Okay. Now, the issue is that the bypasses that the surgeon puts in fail after a number of years, which may or not be discussed with you prior to you signing your surgical form consent. But contrary to what some may think, those bypass grafts don't last forever. In fact, on average, they last 7 to 11 years. So it's not a forever deal. When those bypasses fail, putting stents inside those veins, those bypasses that the surgeon uses, may not be very fruitful, and there can be issues with that, and those stents can then shut down, and then you're back to where you started. So there's a whole branch of interventional cardiology that deals with opening up arteries that have been chronically 100% blocked. That is a procedure that requires specialized tools and, frankly, specialized experience. I'm a big believer, I don't know if I'm in the minority when I say this, but I'm going to give you a little inside Sharma thought. I'm a big believer in doing what is your specialty, what's your niche. But you should also have physicians in your network, colleagues, who have a different niche. So that if I have Mr. Smith and he's got a problem that Dr. Johnson's really good at treating, I'm going to send him to Dr. Johnson. Okay, that's how I look, that's my worldview, okay? I'm giving you a little bit of my personal. But my point is that CTO-PCI, opening up 100% blocked vessels, takes specialized skills, specialized equipment. There's a few physicians in town that are really specialized in it. And if someone is talking to you about opening an artery in your heart that's 100% shut, you probably should try to bring yourself to a physician who specializes in that, which I, by the way, am not. I am not that kind of physician. I can open up blockages that are 99% shut or less. But the 100% shut one takes specialized tools, specialized equipment. I would rather my patient have it done by someone who specializes in that. So for those who are having failing bypass grafts and need that 100% artery open, there are some physicians in town who focus and specialize in that. And those, that is the area that I think your question is referring to. And then that native artery gets opened up, and now the bypass becomes irrelevant, and it's failed anyway. So it is a very risky procedure, though. It can have significant complications. Again, then going back to the point that probably should be done by someone who does a lot of them and has a lot of experience. This gentleman here in the black t-shirt, I'm so sorry, you had your hand up. I feel so guilty. I'd love for you to just ask your question. I'll try to give a quick answer. Yeah, go ahead. Just shout it out.
I had open heart surgery in 2007
Yeah.
for an aortic aneurysm.
Yes.
And I had an aortic valve placed in there. When can I anticipate that needs to be replaced?
So you said it in what year?
2007.
Tomorrow. No. How's that for a direct answer? No. So what you had done was a little bit different, because when the aorta itself, which is an aneurysm, gets replaced, those replacement grafts, they actually hold up pretty much forever. So that part of it is fine. Your question should be more focused towards the valve that was put in. And depending on the kind of valve that was put in when the aorta itself was replaced, again, the estimate is 10 to 15 years. Now, you may outlast that estimate in terms of your valve, or you might be somewhere right there. It could be year 16, year 17, you could have an issue, whatever it is. But again, echocardiograms, ultrasounds, are going to be the key. Every couple of years, those should be getting done on anyone in America with a valve replacement or a valve repair, so that we can track the progression and see it temporally over time and know when to strike when the iron's hot and the valve's fail. So echoes, yeah. Okay.
Sorry.
I'm done. Thank you.
Everyone here has a question for you. Awesome.
You got to play the music. And then
Yeah, play the music. I had, sorry to get the hook out here. I know everyone has their own story and more questions for Dr. Sharma, but that was an awesome presentation. I learned so much. So I know you thought this was free. No. There is a price for all of this. It is in front of you. We really want to know what you want to hear more of. We do about 10 of these coffee connections every year, and also through our Center for Health and Wellbeing, we offer speakers throughout the community. So it's really important to us to understand exactly what you'd like to hear from us. We will not spam you, I promise, and you can even put that on there. I only want to hear about X, Y, and Z. That would be great, and we will make sure not to overwhelm you, but we very much want everyone to complete this form. So I would appreciate if you do that.